Good morning all. Myself Dr. Srikanth Sonune, Assistant Professor in Department of Cardiac Anesthesia at UN Mehta Institute of Cardiology and Research Center. We are welcoming you to this congenital heart disease series on this topic pulmonary venous anomalies with respect to the TE. Coming to the introduction part, the transesophageal echo, it plays a critical role in diagnosis and evaluation of pulmonary venous abnormalities, particularly in congenital heart disease. These anomalies, it includes pulmonary anomalous pulmonary venous return or TAPVR, and T, it provides a high resolution and real-time imaging, specially used intraoperatively when the transthoracic echo is having a limited access. The key learning objectives of this presentation will be to define the standard transesophageal echocardiography imaging planes, which are used to visualize the anatomy of the pulmonary veins, and examine the Doppler flow patterns across the pulmonary veins and distinguish between the normal as well as the abnormal findings. To characterize the most common pulmonary venous anomalies by the transesophageal echo, and to understand the key components of the preoperative and the postoperative T for its assessment of the pulmonary venous anomalies, and to recognize the role of T in defining the complication which are associated with these repairs. Before starting, let's discuss the brief embryology part of the development of pulmonary venous system. So, at the time of gestation, at around 27 to 29 days of gestational life, there is no such formal connection between the lung and the heart. The primitive foregut, it develops and it gives the splanchnic plexus, which forms the connection. It forms the connection for the venous drainage of the lung, especially the lung buds, which further divides into right and left lung buds, and this splanchnic plexus, it gives branches like right and left common cardinal vein, the umbilicovitelline vein, and these are giving the branches of at the around 32 to 33 weeks of days of gestational, there is formation of the common pulmonary veins, which is the only connection at this time with respect to the heart as well as the lung. These common pulmonary vein, then it progresses, and the individual lung veins like right and left upper pulmonic vein as well as the right and left lower pulmonic vein, they open separately, forming a separate ostia behind the opening of behind the LA, and at the time of the term, only the pulmonary vein and their separate openings, it remains, and the process of involution of the common cardinal vein as well as the umbilicovitelline vein, it happens, and thus the separate pulmonary veins are formed at the time of gestation. So, the total anomalous pulmonary venous connection, it results due to the failure to establish the connection between the pulmonary venous plexus and the common pulmonary vein before the connection of the splanchnic venous plexus, it regresses. So, coming to the normal pulmonary venous anatomy, there are four pulmonary veins, namely right upper pulmonic, right lower pulmonic, left upper and the left lower pulmonic vein, which drains into the left atrium. They typically enters the LA separately. The common anatomical variations in these anomalies, it can be like formation of a common trunk or an additional vein or accessory vein can be present. The T, it helps to confirm the number, drainage pattern as well as the orientation. So, this is the schematic representation of the orientation of the heart, which can be seen in the center image. If we draw an imaginary line which is crossing from the base to the apex of the left ventricle, it forms an angle around 100 to 110 degree around, and from this we can take a judgment of if you are seeing at around leftward direction or the rightward direction, the orientation of the respective pulmonary vein on the respective side can be determined on this basis. So, if you are viewing a patient from the left hand side, as we can see, the left upper pulmonic vein is positioned somehow anteriorly as compared to the left lower pulmonic vein, and in case of same scenario is in the in relation with the right upper pulmonic vein as well as the right lower pulmonic vein. And when you are utilizing the transesophageal echo, so you can see the on the schematic diagram, you can see the separate opening of the right as well as the left upper pulmonic and lower pulmonic veins. So, coming to the normal pulmonary vein anatomy and its variants. So, in the first diagram, as we can see, there is a left atrium which receives the blood supply from the right superior pulmonic vein, which and the right superior pulmonic vein and the right middle lobe pulmonary vein, and there is a accessory there is one more right inferior pulmonic vein, and on the left side there is left superior pulmonic vein and the left inferior pulmonic vein. The right superior and the middle lobe pulmonary vein, they join and form the right upper pulmonic vein, and the right lower pulmonic vein is drained separately from the lower lobe of the right lung, and the left lung which drains with the help of left superior as well as the left inferior pulmonic vein, and there are at sometimes the lingular lobe as also having a separate pulmonic vein. The anomalous variants which can be seen are shown in figure second, which can be seen as an accessory right inferior pulmonic vein, or there is a common origin or common trunk formation of the left superior pulmonic vein and the left inferior pulmonic vein. And so, coming to the TE views for the pulmonary veins. So, this is a TE view attained at an mid-esophageal 4-chamber view at 0 degree Celsius. Sorry. हो जाएगा ना? Okay. So, this is the TE view for pulmonary vein which can be achieved at a mid-esophageal 4-chamber view at 0 degrees of multiplane angle. So, to form this view, we have to just withdraw the probe and rotate the probe in the counterclockwise direction, and the structure which are visualized in this echo image from the posterior to the anterior are respectively the descending aorta, the left pulmonary vein and the left atrial appendage can be seen. So, this is another echo image. Basically, this is the transesophageal echo view taken at the mid-esophageal 4-chamber view at angle of 0 degree. In this view, we have focused on the RA and the right upper pulmonic vein origin, and after doing a rightward rotation or the clockwise rotation, the right upper pulmonic vein can be visualized and its course can be traced as it is opening in the left atrium. ये दिख नहीं रहा कुछ भी इसमें. अच्छा ये आपका हो गया आपका? नहीं, ये बाकी है बट ये नहीं हो रहा. हाँ नहीं, दिख नहीं रहा है आधा तो आपके, या तो फिर इसको थोड़ा ऐसा करे. स्लाइड नहीं वो तो लोअर डाउन है, बस ये नहीं तो थोड़ा ऐसा करना जस्ट इन केस वहाँ नहीं दिखा तो इंटरप्शन नहीं होगा. ये बस ये साइड नो ऐसा वो पढ़ना है. हाँ वो नीचे का जो है वो दिख नहीं रहा था एक्चुअली. बस अरे ये तो ऊपर का निकल गया. हाँ ठीक है ठीक. हाँ सेट कर लो आराम से. इसके बाद मैं तो ऊपर है या कैमरा वो की बेस for working stuff. This is a echo image of in this view we can see if the transducer angle is changed to 120 to 125 degrees from the mid-esophageal long axis view. After achieving the mid-esophageal long axis view, we have to rotate the multiplane angle to around 125 degrees and rotate the in the leftward direction. So we'll be visualizing the left lower pulmonic vein as well as the left upper pulmonic vein. This is the classical formation of an inverted V which can be seen, and if you put a colored flow mapping, then the flow of both the upper and lower pulmonic vein can be seen just opening in the left atrium at this side. So this is another echo image. This echo image can be viewed by obtaining the rightward rotation of the probe after achieving the mid-esophageal right ventricular inflow-outflow view at an angle of around 30 to 50 degrees. As we can see in the echo image, the right lower pulmonic vein, the right middle pulmonic vein and the right upper pulmonic vein are visualized with respect to the color flow mapping, and as such there is no obstruction suggestive of the normal flow pattern. This is a spectral Doppler of the pulmonary vein. In this diagram we are comparing the ECG waveform along with the left atrial pressure waveform and the pulmonary vein Doppler tracing, which can be traced after application of the spectral Doppler, and it is compared with the timing of the cardiac cycle. As we can see, the pulmonary vein spectral Doppler waveform is having A wave, an S wave and the D wave. Basically, A wave is the left atrial contraction at the time of A wave is at the time of left atrial contraction, and the S wave, it has two components, namely S1 and the S2. S2 component is basically due to the left ventricular contraction phase, and the S1 is due to the isovolumic contraction phase of the left ventricle, while still the left atrium is receiving the blood from the pulmonary vein, and it is a forward flow. And the diastolic or the D wave is present in the pulmonary vein Doppler waveform, which correlates with the diastolic phase of the cardiac cycle, and the same comparison will be seen in the mitral valve inflow tracing, which is compared with the D wave of the pulmonary vein Doppler. So these are the somewhat variation which can be seen in the pulmonary vein Doppler waveform, as if there is an increase in the amplitude of the A wave, it can be either due to increased atrial contraction or due to the increased LV stiffness or increased LV EDP. So in case of decreased amplitude of the S1 wave, it can be due to the left atrial dysfunction, which is more commonly seen if the patient is in atrial fibrillation. So, and there is an S2 wave which can be increased due to the increase in the LV contractility and decreased by the increase in the LA pressure, and there is increase in the there is decrease in the D wave amplitude, which can be seen if there is an patient is having a diastolic dysfunction, or it is decreased if the patient is having an impaired LV relaxation. Sure. This is a normal pulmonary venous spectral Doppler tracing, which is showing the S wave and the D wave. In the pediatric population, there is no separate delineation of the S1 and S2 wave. Prominent S wave and the D wave can be seen over here, and the S wave, as we have discussed earlier, it represents the systolic forward flow during the left ventricular systole. At this time, the left atrium is relaxing, and hence the pulmonary vein are able to empty into the LA, and the D wave, it represents the diastolic forward flow. This is the echo image of the spectral Doppler tracing of the pulmonary vein, which is not having any specific physical waveform, venous pattern or the waveform pattern which can be seen. And on tracing the waveform, the mean gradient of around 7.8 or 8 millimeters of mercury can be traced, and there is a flow turbulence which can be seen on the color flow mapping, which is suggestive of pulmonary vein obstruction. So coming to the anomalous portion of this presentation. So pulmonary venous anomaly, it can be either a partial anomalous pulmonary venous connection. The incidence of PAPVC is around less than 0.4%. It is most commonly associated with the atrial septal defect. Out of that, the sinus venosus or the SVC type of sinus venosus ASD is having a most common association with the PAPVC, around 75%. The severity of the symptom, it depends on the number of abnormal venous connection and the presence of atrial septal defect. Most commonly, the right upper pulmonic vein, it drains at an SVC to RA junction, which causes the right-sided volume overload. So, there is an echo image depicting a teardrop shape which is caused by the anomalous right upper pulmonic vein as it enters the superior vena cava. This image can be achieved after having a mid-esophageal 4-chamber view, which is focused on the SVC and the RA junction, and you have to slightly withdraw the probe to mid-esophageal ascending aorta short axis view, and the change of SVC shape has to be looked for. The circular shaped SVC shape will be changed into a teardrop shape as there is a connection between the SVC and the right upper pulmonic vein. The anomalous venous connection to the free wall of the RA, it is detected by advancing the probe and rotating the probe to the rightward and tracing the IVC. And in these, after doing the tracing, we can visualize if a rare or abnormal venous connection with the IVC. So in this type, for this detection of the IVC type of sinus venosus ASD. So left-sided PAPVC is also common. It joins the left pulmonic vein via the vertical vein to the left innominate vein and finally draining into SVC. So there is some post-operative consideration which are relevant for the PAPVC. We have to make sure that the venous obstruction is not there in the post-operative period, and we have to exclude the residual shunting, if any. So this is the echo image which of a patient who have undergone the sinus venosus ASD repair, and the baffle which was created to divert the blood from the blood to the left atrium, it shows the unobstructed systemic as well as the pulmonary venous return. Now coming to the discussion of scimitar syndrome. So it is a rare syndrome which can be due to either partial or the total anomalies pulmonary venous drainage from the right lung to the IVC. It is associated with the hypoplasia of the right lung and the right pulmonary artery, and there is an anomalous blood supply to the right lung from the abdominal aorta. As we can see in the X-ray image, there is an appearance of a typical sword-like structure which can be seen, and there is hypoplasia of the right lung. And there is a schematic diagram in the middle of your slide which depicts there is hypoplasia of the right-sided lung, and the pulmonary artery, it receives the lung, it receives the blood supply from the intra-abdominal portion of the aorta. The anomalous pulmonary vein, it creates an appearance of a Turkish sword, hence named a scimitar syndrome. T can be utilized for this view is suggestive of an abnormal scimitar vein which can be traced at this angle of around 110 degrees. So to achieve this image, we have to first position the transesophageal echo probe at a transgastric position of around 0 to 20 degree. Then at this position, we have to advance the probe at a level of deep transgastric around 20 degrees, and then increase the multiplane angle of around 50 to 70 degrees and achieve the deep transgastric RV outflow view. And after doing a clockwise rotation at this level, the IVC can be seen in the entire length. So after tracing the IVC through the length, the abnormal or scimitar vein abnormal venous connection can be seen, which can be traced at around 110 to 120 degrees. So the PAPVC, it can either be due to malposition of the septum primum, and in this case there is leftward deviation of the septum primum. The pulmonary vein, it connects the normally, but due to the atrial septal deviation, it directs the blood flow to the right atrium. So coming to the TAPVC or the TAPVR, so basically in this case there is an abnormal drainage of pulmonary venous blood into the systemic venous blood, and the incidence is around 2.2% of all the congenital heart diseases. So the classification of the total anomalous pulmonary venous connection, it was given by the Darling and Associates. Basically there are 4 types of TAPVC: type 1, type 2, type 3 and type 4. Namely, like type 1 is supracardiac TAPVC, the incidence is around 45 to 55%. Type 2 is cardiac or coronary sinus type of TAPVC, the incidence is around 15 to 20%. Type 3 is the infracardiac, around 15 to 20%, and type 4 is having a mixed type of TAPVC, which are having either the component of both supracardiac as well as cardiac or infracardiac origin. The incidence is rare, it is around 5 to 10%. The other classification which were given are Smith classification and the Edward classification. So coming to the pathophysiology of the total anomalous pulmonary venous connection, it depends on whether the pulmonary venous flow is obstructed or non-obstructed. Obstruction, it will lead to increase in the pulmonary venous hypertension, and it can lead to the higher back pressure changes. All the pulmonary venous blood which returns to the right atrium, and this is the site for the common mixing chamber. Right to left shunt at this level of the is seen. The level of the degree of shunting, it depends on the RV compliance, the size of the ASD, and whenever there is an increased pulmonary blood flow and the pulmonary venous obstruction, it will eventually result in the pulmonary hypertension. So TE examination can be helpful in the TAPVC, but there is always a risk of hypotension due to the compression of pulmonary venous confluence. So it is better avoided in case of neonates due to this potential risk. So to overcome this risk, we can use the epicardial echo for the intraoperative evaluation. So the complete preoperative evaluation of the TAPVC, it includes, we have to identify the pulmonary venous confluence, and we will delineate on the individual veins which are joining the confluence, and we have to assess the site of the drainage and whether there is any venous obstruction or any associated intracardiac anatomy or the associated intracardiac lesion is there. Coming to the supracardiac TAPVC type, this is the most common type of TAPVC. The pulmonary vein confluence is located between the esophagus and the left atrium. The confluence is located just posteriorly and the inferior to the central pulmonary artery. As we can see in the echo image, the pulmonary vein is posterior and the pulmonary artery is anterior to it. So this is a schematic diagram which shows the supracardiac type of the TAPVC. In this we can see the pulmonary vein, they join together and forms the venous confluence, which ultimately drains via the ascending vertical vein to the innominate vein, and it drains further into SVC via the SVC into the right atrium. And based on the size of an atrial septal defect, it drains the blood in the left atrium and forms the cardiac output. Drainage of the supracardiac TAPVC is via the vertical vein and ultimately draining in the left innominate vein. This upper esophageal aortic arch short axis view has to be achieved to see the vertical vein as well as the innominate vein color flow mapping. So the supracardiac TAPVC obstruction, it can occur in the ascending vertical vein connecting the pulmonary venous confluence to the left innominate vein, and the passage of the vertical vein between the left pulmonary artery and the left bronchus is the cause of compression of this vessel, and it subsequently leads to decrease or egression of the pulmonary venous blood flow. Coming to the cardiac type of TAPVC, in this type, as we can see in the echo image, the coronary sinus, it appears to be dilated and there is a common chamber or the atrial septal defect can be seen. The pulmonary veins, it drains directly into the right atrium or in the coronary sinus, and the confluence is not appreciated at this type of TAPVC. The mid-esophageal four-chamber view has to be attained at an angle of 0 degree. With a slight retroflexion, we can achieve the coronary sinus view, and the pulmonary vein, it drains into the coronary sinus and it appears to be dilated. It is very difficult to separate the left atria and the coronary sinus due to the abnormal dilatation of the CS. The infracardiac type or the type 3, it is around 12%, 12 to 15%. The long pulmonary vein, it courses down along the esophagus, as there is no such formation of any pulmonary vein confluence in this type of TAPVC. The vertical vein, it appears as a Christmas tree pattern giving branches, and it empties into the either inferior vena cava or the portal vein, which is the more common site. The vein, it gets constricted by the diaphragm as it passes through the esophageal hiatus, and the pulmonary vein, it gets obstructed at the level of either ductus venosus or the hepatic sinusoidal level. So the presentation is it presents with the congestive heart failure in most of the cases, which is secondary due to the obstruction of the vena cava, venous obstruction, and the venous return is obstructed, and the patient can present with an cyanosis and secondary to the right to left shunt through an ASD, and most of the infracardiac TAPVCs are associated with either asplenia or polysplenia. Out of all types of TAPVC, the infracardiac type of TAPVC is having a worst outcomes. So coming to the postoperative TE assessment, we have to look for the size of the left atrium after the repair of TAPVC, and the size of left ventricle and the mitral as well as the aortic valves. There will be an increase in the transmitral flow velocities as the ASD patch has been closed at this time, and we have to make sure that there would be decrease in the coronary sinus blood flow, or the coronary sinus flow cannot be appreciated after closure of or repair of the TAPVC repair. So we have to assess the biventricular function, and we have to check the integrity of ASD patch, and we have to make sure that there is no gradient across the confluence and the respective or individual pulmonary vein, they are having the unobstructive blood flow. Coming to the other variant of pulmonary venous anomalies, so this is co-triatriatum. It is a rare congenital anomaly. The incidence is around 0.1%. The classic co-triatriatum, it consists of a common pulmonary confluence which are separated from the left atrium by a thick fibromuscular band. This fibromuscular band is formed due to either malseptation or the entrapment or malincorporation of the pulmonary vein confluence. It is because of this fibromuscular band, the atria is divided into two halves, the superior chamber and the inferior chamber. The superior chamber, it receives the blood from the pulmonary vein, and the inferior chamber is in continuity with an aortic wall as well as the left ventricle. There is the echo image which can be seen, the mitral wall leaflet, typically AML and the PML is seen over this in this view, and the thick fibrous band which separates the left atria from the AV wall is seen. So this is the classic presentation of the co-triatriatum, which can mimic like mitral stenosis. T is the cornerstone imaging modalities for diagnosing and managing the pulmonary venous anomalies, especially in the congenital heart diseases. So it provides the real-time imaging as well as the high resolution and visualization of the pulmonary venous connection, and it helps to detect the anomalous drainage pattern. So in case of TAPVC and the PAPVC, the T, it enables the accurate assessment of the site and the type of anomalous connection, the flow direction, the site of obstruction and the chamber enlargement. We have to look for any associated defects such as ASDs. For the intraoperative assessment, the T, it is helpful in the surgical planning, the placement of the patch, and the confirmation of the unobstructed pulmonary venous return after the surgical repair. So 3DT can be used. It enhances the anatomic details, particularly valuable in mixed type of anomalies and in case of the redo surgeries. So post-operatively, T, it ensures the effective surgical repair, and it rules out the residual defects, and it can monitor the pulmonary venous flow. Thank you.